Welcome everyone. It is 10:15, so we're going to get started. Welcome to this session of the 2020 Culture of Data Conference. Thank you all for joining us. My name is Kelsey Fife Duarte. My pronouns are she, her, hers, and I will be moderating this session. We also have Carolyn Bryan, she, her, hers, who is managing Zoom and making sure tech is running smoothly. So if you have any sort of tech issues, you can reach out to her and hopefully we'll get those resolved for you. You are all muted now so that we can hear our presenters well. But if you have a question during our Q&A sessions, feel free to unmute yourself. You can also use the chat box throughout the presentations to throw any comments or questions that you have as they come up during the presentations. If you're comfortable doing so, we've said this a few times throughout our conference the last couple of days, but feel free to add your pronouns to your name on your Zoom screen. You can do that by clicking the 3 dots on your video square and selecting rename. And we're going to just dive right into our presentations. And if I look like I don't know where I'm looking, it's because I have multiple screens up, so pardon me. So we're going to have 2 presentations during this session. Each will be 20 minutes, followed by a 10-minute Q&A session. And we'll have a 5-minute break in between the 2 presentations to give everyone time to stand up and do what you need to do. All right, so the theme of the session that you're in right now is institutional racism and the pandemic, which I think we're all very familiar with and is a very relevant topic related to the theme of our conference, as we heard in the opening session today. So I think this will be a really great follow-up to what we heard earlier this morning. Our first presentation is Online COVID-19 Vaccine Narratives That Invoke Medical Racism, Understanding Health Myths and Disinformation. This presentation is by Lindsay Diamond, and I'll hand it over to her.
Thank you so much. I will share my screen. Thanks so much, everyone, for being here, and good morning. I have to say, I'm coming to you all from the Information Science Department at CU Boulder. I am a huge fan and in love with public health, though this work may look slightly different than some of the presentations. So I will take some time just to familiarize with some of the work and also some of the ethics that we deal with in this field as well. So it's been an absolute pleasure and absolutely inspiring to listen to all of the people who are working with and partnering with and within communities. This work starts locally, but then pretty quickly moves to a more national and international space. And so I just wanted to ground that importance in the fact that with every passing year, more and more people are turning to social media to get health information. And so this work starts out of something that happened here in Denver, but trying to help understand a little bit more of how these narratives that are happening on social media can impact even our local communities. So I begin in June 2020. I was in Denver and 2 different groups had gathered in protest. And so on one hand, we had people who were marching in support of Black Lives Matter. And at the nearby state capitol, we also had anti-vaccine activists who were at the Capitol protesting a vaccine-related piece of legislation. This protest actually drew some quite prominent activists, such as Robert F. Kennedy Jr. And among this crowd were also the local Proud Boys, gun rights activists, and other alt-right and conservative groups. And at one point during this sort of confluence of protesters, the anti-vaccine activists started yelling out to some of the Black Lives Matter passersby to remember Tuskegee and to refuse the COVID-19 vaccine. Now, this image is actually from the Los Angeles Times, but there were similar signs and references happening at this time. And so I thought this sign kind of sums up perfectly what we had to unpack with what was happening here in Denver. And that got me interested in if we were seeing this locally in the Denver area, is this something that was happening nationally? And also, what does this look like in an online space? Now, remember, Tuskegee is, of course, in reference to the Tuskegee syphilis study. Sorry, my slides are not advancing. There we go. Obviously, in a public health conference, I don't have to describe this, but I will say from my research, most of the audiences I've had the opportunity to present this research to continuously with shows of hands are only loosely familiar with or completely unaware of the Tuskegee syphilis study. And so I just wanted to mention that this is quite tragic because we can't hide from past atrocities, but also in doing so opens the door for mis and disinformation. And it's important to note that the misrepresentation of this study is quite frequent, and it's a big part of our study. So there was a lot of confusion around what had actually taken place during the study. So when we look at Twitter data, we find that most vaccine hesitant users believe that participants in the study were actually given syphilis. And there's a really common narrative that they were not only given syphilis, but actually given syphilis through the use of vaccines. And so this obviously leads to a lot of questions and confusions and sort of this somewhat false correlation between being pro-vaccine or trying to help communities engage with vaccines and bringing up the Tuskegee syphilis study. And so we have this layer of this confusion or misrepresentation of the Tuskegee syphilis study. And then that gets layered on top of the fact that for as long as there have been vaccines, there's been vaccine hesitancy. Obviously, this goes back to the 1700s, but in terms of sort of group activity or a collective activity, the Anti-Vaccination Society of America goes back to 1879. In the more modern era, we see activities of targeting of minority populations. So this has occurred in Orthodox Jewish populations in New York, Somali communities in Minnesota. And so now we know the anti-vaccine movement has expanded, and it begs the question, what happens when those who fear or doubt vaccines out of mistrust of the government or political party or scientific authority see this new frontier to evangelize to those who are legitimately fearful of medical racism. And so our research aimed to understand three main things. One was how those who are concerned about medical racism speak about compliance concerns in relation to the COVID-19 pandemic, whether disinformation activity that exploits medical racism is happening, and to what extent spaces that are traditionally the province of Black Twitter are infiltrated by people with intent to disrupt. So we examined this discussion space on Twitter, which was created by the combined invocation of the Tuskegee syphilis study and vaccinations to better understand how and why medical racism are argued. So I start here. This is a chart of tweet frequency. So we're going all the way back to 2018, looking for any tweets that combine a reference to Tuskegee and then also vaccines. And this will include common misspellings or shorthand like vax, V-A-X. And so we try to combine, make it inclusive of all the terms that people might use to reference the Tuskegee syphilis study and also vaccines. So what you can see from this chart is this was a relatively or almost entirely quiet space going as far back as 2018. There are little blips along the way that you can see, and sometimes those are references to the Tuskegee Airmen, but somebody was just talking about vaccines as well. And then we enter into the pandemic period. And you start to see a little bit more activity. And of course, perhaps what is most noticeable is we have this huge spike at the time that NBC and some other media outlets ran a headline that a COVID-19 vaccine will work only if trials include Black participants, experts say. Now, it's probably not terribly surprising that headlines like that would conjure up images and thoughts about the Tuskegee syphilis study. But this chart should just also represent that obviously media drives a lot of the conversations we see in online spaces. So other spikes in frequency of terms or tweets that use these terms include things in November, where there was a tweet from Alana Presley that said Black Lives Matter also means that there's a strategy to combat Black Americans' vaccine fears and skepticism because of the Tuskegee experiment. And then, of course, we have the first vaccine given in the United States in December, and we have these other narratives. So, in February, the LA Times, Los Angeles Times ran a headline, "Decades later, infamous Tuskegee syphilis study stirs wariness in Black community over COVID-19 vaccine." But then shortly thereafter, in March, we see the NPR headline, "Stop blaming Tuskegee. Critics say it's not an excuse for current medical racism." So this space is complicated. The title of the paper has polyvocality in it because we see many voices, in this one discussion space. So just to give a reference, we go back to Twitter, we collect all of these tweets. In doing so, we had about 17,000 tweets that we divided into what we call the pre and peri-pandemic periods. And that is February 1st of 2020. So anything that happened before that is considered pre-pandemic, and anything that has happened since would be peri-pandemic. And so through empirical inspection, and we use thresholds for people who persist in this conversation space over time, we were able to filter it down to about 538 accounts and about 3,000 tweets that we were more interested in deeply analyzing. And so, as I mentioned, this idea of polyvocality actually comes from work from Bakhtin, who is a Russian researcher and thought leader. And this idea that there is a mixed space of positions, agendas, and their resulting logics. So we have a coding scheme. So myself and another researcher coded each of those 3,000 tweets and found that we could identify about 15 or so in-kind groupings of how these different voices that we were seeing appearing in the space. And we were able to ultimately get to the place of these 12 distinct voices. I will say the paper goes into really in-depth descriptions of the voices, but for the sake of time, I want to spend a little bit more time about the interactions of these voices and describing what this space looked like. So I'll spend a minute here. I know this is a lot of text, but those 12 voices that we were able to pull out of this conversation space has both the level of vaccine hesitancy or pro-vaccine. So we see vaccine distrustful speakers. We also see pro-vaccine speakers. In terms of identity, so we don't go into the research with any preset features. We just let speakers in the space of Twitter sort of tell us anything that they can report about their religious identity, their racial identity. And so while you will see speakers who are publicly presenting as Black, you won't necessarily see publicly presenting as anything else. And that's because, as you can imagine, trying to assign race or gender or other features to Twitter users is complicated and ethically problematic. So the only time that we can assign these features are when they are publicly presenting themselves as such. This is the same for political stance. So there are users in the space who continuously invoke political conservatism, but we don't necessarily see that, and we don't force a left-leaning or liberal stance. So early in the pandemic, what we saw was sort of three main voices. This was, sorry, not early in the pandemic, before the pandemic, we typically saw vaccine distrustful speakers who invoke political conservatism. We saw vaccine distrustful speakers who don't offer strong positions of their identity. And then we have pro-vaccine speakers who do not offer strong positions of identity, and pro-vaccine speakers who publicly identify as Black. And in this space, this pre-pandemic period, this is mostly just truthfully, like anti-vaccine and pro-vaccine activists kind of sparring, going back and forth about information, misinformation, disinformation. And it's just a lot of misinforming and trying to debunk that information. But as we move into the pandemic period, we see a rise in many more voices. And so we see, more vaccine distrustful speakers who publicly identify as Black. We see voices from Black presenting speakers who make it known their connections to lineage and reparations movements like Foundational Black Americans and American Descendants of Slavery. We see Black presenting speakers connected to the Nation of Islam. We also see a very small portion, but of vaccine distrustful and publicly presenting as Black speakers who invoke political conservative speaking points. We also have things like people who've moved from vaccine distrust to pro-vaccine over the course of the pandemic, which is exciting. And those are users that are interesting to see where they land or who they were communicating with. And then we also have a small group of users that we call mixed content, which means that over the course of time, they may have posted both pro and vaccine hesitant content, and it's not chronologically clear where they stand. So we turn to network science, and this is the ability for us to look at these users that we're studying and how they connect to each other. Now, we somewhat affectionately or grossly call these hairballs. And so this is a network diagram of the pre-pandemic period. And I just want to point out, so each circle or node is one of the users in this data set. And the lines that are drawn between them, or these edges, are mentions or replies. So these are all of the tweets that occurred between the users, whether or not they had to do with Tuskegee vaccines over the course of our time period. And so this actually represents 19 million tweets in this hairball. So one of the things that's interesting about the pre-pandemic period is that a lot of the voices actually fall along racial and social and political lines there, and then some adjacent neighbors. And so on the top circle, we actually have what is often considered the province of Black Twitter. So these are mostly Black presenting users. There are a lot of connections between these users even before the pandemic, many of which these tweets, or the majority of these tweets, are not necessarily about Tuskegee and vaccines. The bottom are the sort of canonical anti-vaccine Twitter users kind of sparring and going back and forth with pro-vaccine speakers. And I want to mention, in terms of sort of some of the ethics around this type of work, not a lot of Twitter users understand that their data are public, that when they put a tweet out for the world to see, that becomes public data. And this is sort of interesting when it comes to things like IRB or research ethics, because we're not actually required to get full IRB to study tweets. And that's because this is public data. But our field as a whole has moved in the direction of trying to err on the side of privacy and protection. So what you see here and in the paper is that we have actually, we are not sharing identity or usernames for the vast majority of speakers in this data set. The ones that you see here are affiliated with prominent speakers on Twitter who are Twitter verified. They have huge followings. They often appear or are media personalities. And so we feel that, a small academic paper somewhere out there is unlikely to draw attention to them or uncomfortable attention. So one of the other things that to notice here is also just if you recognize some of these names or some of these connectors. Toure is a Black media personality who's been extremely pro-vaccine and very helpful in communicating to the Black community about the COVID-19 pandemic. And you can see there's, he's serving in this sort of bridge area where we have connections within the speakers in the top circle, but also connections and interactions with anti-vaccine speakers in the bottom. And what happens during the pandemic is that we have this rise in this pro-vaccine Black presenting speakers. And so, this is one of the biggest things that happened during the pandemic, is a lot of misinformation and disinformation activity was happening. And so it sort of became the burden of Black presenting public health officials, doctors, scientists to spend a lot of time debunking this misinformation and trying to provide good quality health information on Twitter. So this amount of activity here really skyrocketed in the amount of energy it took to debunk this information as well. And then one of the things that's really hard to tell from those hairballs is that all of the voices were together. So it was a little bit hard to pick out certain things from each other. So with this, we were actually able to pull out just the vaccine distrustful speakers. And so this is before the pandemic. You can see that there isn't a lot of activity between vaccine distrustful speakers on the politically conservative side, who are Invoke political conservatives, and those who are Black presenting. And this isn't necessarily surprising, as many of the users in this, the top left side are vocally supporting policies that further harm, communities of color. However, in the pandemic period, we see that the amount of communications goes up by 84%. So these connections between these politically conservative vaccine distrustful speakers and Black presenting vaccine distrustful speakers. And a lot of this is targeted behavior. And I just want to point out that these Black nodes that are kind of in the center here, these are suspicious accounts. Now, we don't know whether they, what they are serving, but they have features that are suspicious. And so they're operating at these bridges between these two groups. And we know that this is a big problem with mis and disinformation. So, in terms of the nature of disinformation, one of the problems with this work and with this type of disinformation is that the Tuskegee syphilis study is so offensive that it actually takes a minute to explain that parts of it are being hijacked or exploited to tell further untruths that cause harm. And so we discuss disinformation as this foreground background trick. And so it ostensibly speaks to one foregrounded issue like vaccine safety, but it keeps the agenda, in the background and a little bit obscure to its audience. And it's really just a masquerade. And so this is one of the things that we, are most concerned about. We also think a lot about technological responsibility. Basically Twitter just is an authority. It creates validity to any voice that's on the platform. And disinformation is not just a collection of single pieces of incorrect information. Its production is wrapped up in positionality and the intention to attack in uncertain situations. And so in terms of public health, one of the things that we think about and would love to partner with, people from within public health is just that medical racism, past and present, continues to haunt public health recommendations, and atrocities like the Tuskegee syphilis study need to be ongoingly addressed in public health messaging, because this kind of misinformation told as stories is really powerful, and it's a challenge to undo, particularly when it invokes legitimate tragedies. So our hope is that public health or health communications can address these past offenses, even when the events seem to have little connection to the matter at hand. And also to address, valid concerns, public health groups and advocacy groups have to attend to local speakers in communities. Obviously, there's been a lot of effort and much better talks on that, which have been truly inspiring to me. And so I think, this work is just to look at, if we surveil places like social media, we may be able to see the kinds of things, the kinds of narratives or mis and disinformation that are happening in these online spaces before they sort of filter down and into our communities, to help us prepare for what kind of hesitations or concerns or narratives might show up in our local communities. And so with that, I thank you for your time, and I look forward to your questions.
Thank you so much, Lindsay. It was a wonderful presentation on a topic that, like as you mentioned, maybe a little less familiar of a space to those of us, but very, very relevant to the work that we or our colleagues are trying to do. We've talked a lot as a planning committee about how public health communications, specifically around data, could be improved and worked on. So we have about 8-ish minutes for questions, and we do have a couple in the chat. So Carolyn popped one in there, wondering how do the interactions account for interactions or responses from bots?
It's a great question. So the black nodes in those hairballs that I mentioned as suspicious is sort of our best way at dealing with that, because as it turns out, with every passing day, what we once referred to as bots are becoming ever more challenging to really be able to say that that's what they are, because they become more sophisticated over time. There's also this complication that is something that in this field and in the social media world is called a cyborg, which is sort of a funny term for this, but it's essentially that there are actual humans who are either paid or voluntarily creating these accounts and tweeting. So they're not necessarily automated bots, but they are inauthentic in that people are either being paid to or voluntarily spreading mis and disinformation. So the way we deal with that is that we look for the cues that accounts are suspicious, that they're inauthentic, and we do our best to label those as such. But it is challenging because they are becoming increasingly, more difficult to be able to truly say that something is a bot or a cyborg. But it's a great question.
Another question from the crowd. In your research, did you see any major themes, events, articles, etc., that swayed folks from anti-vaccine to pro-vaccine?
Another great question. One of the really interesting things that we saw in the hairballs was that most of the people who went from anti-vaccine to pro-vaccine or vaccine distrustful to pro-vaccine were nestled really tightly within the community of pro-vaccine Black presenting speakers, which is to say that I think, our hope and something that we're going to look a little bit more deeply into as we dig into these networks a bit more is that just access and frequency of positive communications from people within a community and sort of repetitive communications seem to have impacted some of these users from going from vaccine distrustful to pro-vaccine. And when I say pro-vaccine in this case, that for us to be able to be in that voice was just that somewhere in our data set, they go from speaking in a distrustful way to publicly announcing that they've been vaccinated. And so I wouldn't say that we can't call them pro-vaccine across the board, but that's the big thing that we were looking at was just, to go from distrustful to publicly announcing that you got your vaccine, is a big step and something that we were really excited to see. I think one of the other things that we saw is while the media and these kinds of headlines spur a lot of conversation, they don't seem to be the thing that's actually changing people's minds. It's these one-off, replies and Twitter threads and communications. So, presumably human to human most of the time in these cases where the direct ability to address someone's concern or hesitation seems to have the most impact.
Thank you. Feel free to throw any other questions you have in the chat or unmute yourself if you want to add to the voices that we're hearing in the session today. This is maybe a small detail, but something that stood out to me that you mentioned earlier. Oh, I'll go into the question here because it's a nitty-gritty detail I had. So they're wondering about accessing your research outside of this presentation. You mentioned a
Sure.
paper.
I will actually link to the paper in the chat as soon as we're done here, so you can access the full paper.
That would be great. Wonderful. At the end, I really liked your wrap up, connecting this back to how this is relevant to public health. And I wonder if you have any recommendations on how we can help build the relationship between public health partners and researchers such as yourself that have the skills to dig into social media and help us kind of understand how we can use that information.
Yeah, I was going to say, if there was any time, I was just going to plug that we are fully aware of the fact that we are not operating within the public health space, but would love to partner with and work with people who are, as I said, I think, the work in communities is far more important than this, but I'm hopeful that having access to some of this research could help folks know what kinds of narratives and things that are happening in social media, so that it's sort of just an awareness, like a light surveillance that's happening in the background, so that we could just prepare people who are working within communities or public health communicators of the kinds of things we're seeing show up in these online spaces as sort of preparation, both for materials or just the kinds of conversations. And we're also trying to just figure out where are they coming from. So maybe if we can like source the cause of this, we can come up with communications and ways to address this before, I feel like these were seeds that were planted pre-pandemic and then were fertilized by the pandemic. And so we want to get to the point where we can actually get those seeds out of the ground and not even have this sort of growth cycle. So I would love to work with public health. I know our whole research group would. So I absolutely open any opportunities to collaborate.
Wonderful, thank you. And I like that metaphor you use about the seed. Something I was thinking about when I was preparing to moderate was how these approaches can be done proactively, used in a proactive way as opposed to reactively. I think what you've described today is a great starting place and something to grow from. So thank you so much for your presentation. We are going to move into a 5-minute break. So at 10:52, we'll reconvene and have our next presentation. Let's forgot to unmute myself. We are gonna get started with our second presentation for this session. We are going to be hearing the presentation called COVID-19 Diagnoses by Census Tract. CHORDS, I'm assuming CHORDS, data show the disparate impact of the pandemic on different neighborhoods in the Front Range. This will be presented by Guadalupe, Solís, and Lindsay, Whittington.
All right, let me just are you seeing my screen?
Yes.
Okay, thank you. All right, thank you so much for having us here today. Guadalupe and I are super excited to share with you a project that we got to work on last summer with data partners at the CHORDS network. I think this project is a really good example of taking data that we have available and integrating a creative approach to really tell a story of impact. And these specific data showcase findings about where people live in Colorado and what that meant for COVID-19 last year. So let's dive in and show you what we did. So first, I wanted to provide a little bit of background about the Colorado Health Institute and what we do. So I hope that most of you are familiar with the Colorado Health Institute. We are a nonprofit, nonpartisan provider of independent data and evidence-based analysis to support decision makers in Colorado who really work to advance health policy and health access in our state. So we work with people at all levels, from community groups to large health systems, who really want to improve health for Coloradans. And we are really thinking about how health equity and access to quality care really fits into all of this and this different conversations, which I think is reflective of this project that we're sharing with you all today, because where you live in Colorado matters, and access to care by different Coloradans is not always the same. So let's start off by introducing ourselves. So my name is Lindsay Whittington, and I'm a policy analyst at the Colorado Health Institute. I've worked here for about 2.5 years, and I'm one of the geospatial analysts at CHI. And I work on different approaches where we can visualize data in new, innovative ways. And I'm joined by my colleague Guadalupe, who I'll let introduce herself as well.
Thanks, Lindsay. Hi, everyone. Good morning, and thanks all for being with us here today. My name is Guadalupe. My pronouns are she, her, ella. I work as a research analyst at the Colorado Health Institute. My family has lived in Denver for decades, and it is a place that we call home. And so the communities of Denver and the Front Range hold a very special place in my heart. And this is why I'm here with you all presenting this data. I'm looking forward to going over what we planned today, especially as Lindsay recapped, but I'll pass it over to her. Nice to meet you all, to take us into the project overview. Thanks, Lindsay.
Awesome, thanks, Guadalupe. All right, so now let's talk about the project that we're presenting on. So last summer, CHI was really interested in understanding more about how COVID-19 was impacting certain Colorado residents across our state. So, at this time, there was lots more information coming out about those who were disproportionately impacted by the pandemic. And that's not just about those who were more likely to get COVID, but also more likely to feel the impact of other factors like job loss, and also different levels of access to vaccines during this same time period. So this really led us to ask two key research questions that started the momentum behind this mapping project. And the first one being, how did different communities fare during the COVID-19 pandemic? And the second one, were there certain communities that were more impacted than others? So we were interested not just in these health outcomes, but also social and economic factors that might impact someone getting a COVID-19 diagnosis. So we asked ourselves, what data sources are available that can help us answer these questions? So one of these key data sources came from our partnership with the Colorado Health Observation Regional Data Service, which is also known as CHORDS. So this regional collaborative is a unique set of partners that covers healthcare, public health, behavioral health, and brings together electronic health record data to help identify health trends and support public health evaluation and monitoring efforts. So some of the different health outcomes that are studied and monitored because of CHORDS includes efforts around diabetes, depression, hypertension, and really so much more that's available through their data set. So we saw that this data source was a perfect player to really help us understand COVID-19 diagnoses across the Front Range and help us answer our research questions for our project. So thanks to our partnership with CHORDS and working with our data partners there, we were able to get data at the census tract level on the care-seeking population and COVID-19 diagnoses across Colorado's Front Range. So these data were diagnoses data that spanned between April of 2020 and March 2021. We then brought in key factors that are important systemically rooted factors that influence a person's health and health access. So these included language, race, ethnicity, and education. So these factors we gathered from the 2019 American Community Survey. So we then created an interactive mapping application using ArcGIS Online that brought these two data sources together and really helped paint a picture of these impacts, tell a story with these data, and visually was able to convey our key findings, I think, in a way that a report would not have been able to. And I think it really showcases these differences in a really creative way that really leaves an impact with these data. So before we jump into the actual application, I wanted to share the 3 key findings from our analysis, and then Guadalupe is going to dive deeper into these findings using the mapping application. So first, in the hardest hit metro neighborhoods, the rate of COVID diagnoses was 10 times greater than in the ones that fared the best. And just a drive of just 10 minutes separated some of these different neighborhoods that had the highest concentrations of COVID diagnoses from areas that largely escaped the virus. And lastly, the highest diagnoses levels were found in neighborhoods where residents had lower education levels, more residents who spoke a language other than English, and where more people of color lived. So now I'm going to pass it over to Guadalupe to showcase the mapping application and these different findings that I just talked about.
Thank you, Lindsay. I'm going to go ahead and share my screen. Screen 3. Perfect. Okay, thank you. So I'm going to be driving us through the application, some implications, and also lessons learned. But before I begin, I would like to also do a plug for the Spanish version of our mapping application, which is available here if you follow my mouse in the En Español link. So, if the language of your heart is in Spanish, or if you know of others who would be interested in seeing this in Spanish, please feel free to share that with them. So to further dive into the key takeaways or take home the key takeaways that Lindsay just introduced for us, I'd like to orient us to the section of our application focused on where we zoom into specific neighborhoods. But before then, this is what our application looks like on the website. We do an introduction, some key takeaways, what we did, and a little bit more context and level setting. Here's where I'd like to focus. And so in the hardest hit metro neighborhoods, as Lindsay mentioned, the rate of COVID diagnoses was significantly greater than the ones that fared the best. And so here you see 2 neighborhoods, the neighborhoods of Westwood and Platt Park, which are just a 10-minute drive from one another. Yet Westwood was among the list of neighborhoods with the highest concentration of COVID-19 diagnoses, and Platt Park over here on the right, Westwood here on the left, fared better than that and largely escaped the virus. And so that is a significantly greater difference, despite the fact that the 2 neighborhoods are just 10 minutes away from each other. So if you click on any of these census tracts, Westwood has a COVID-19 index of 191% of the average. And just 10 minutes away, you click on Platt Park, and they had 47% of the average. So 47% compared to 191 is a pretty big difference. So another key takeaway mentioned was that the highest diagnoses levels were found in neighborhoods where residents had lower educational attainment, more residents who spoke a language other than English, and where more people of color lived. And so I'm going to guide you through the next social factor that we looked at, which is educational attainment. And so here we're looking at neighborhoods by educational attainment on the right side. In the blue here, and the neighborhood shaded a darker color means that there are a higher percent of residents with less than a high school diploma. And then here on the left, sorry, getting mixed up, here on the left, the orange are the neighborhoods or the census tract with a darker shading orange had the higher case of COVID-19 diagnoses. And so here you can see really the clear differences, right? In terms of the areas that are lighting darker on both sides. So lower educational attainment is lighting up darker also for COVID-19 diagnoses. You see this in Southwest Denver, Lakewood area, Northern Denver, metro area, Thornton, Montbello, Northeast Denver. And so these are very significant exposure patterns that we saw, right? And one thing that I do want to clarify here is that we are not presenting this data to place the onus and responsibility on the people who live in these communities for the higher rates of diagnoses that they experienced. Rather, we are presenting this data to place the onus and cause on the clear systemic and social barriers that these communities have historically experienced, which have led to these outcomes. A common example is that those with the lower educational attainment are more likely to have jobs that do not come with the option to telework or work remotely. Another example is the lack of safety and PPE that was present at these types of jobs, which left workers at higher risk of exposure. That happened at restaurants, factories, and meatpacking plants and grocery stores. And lastly, these patterns are not solely due to the individual choice not to go to college, but more really to the, again, systemic and institutional barriers that make it harder for historically marginalized groups to be able to pursue an education as easily as others. And so we see that here reflected in this map. I'm going to go ahead and scroll to our racial and ethnic diversity part of our application. And so here we see a similar overlap as it loads with racial and ethnic diversity and higher rates of diagnoses. And so if I zoom out a little bit, here on the left, the areas that shade in darker purple are the neighborhoods or census tracts that have the highest percent people of color. On the left here are COVID diagnoses. So the darker shaded orange are census tracts or neighborhoods that also had the highest diagnoses of COVID. And so we literally see similar overlap between these two areas, right? Lakewood again, Southwest Denver, Aurora, Northeast Denver area, and North Denver. And so what neighborhoods that have a higher percent of people of color have in common are that residents are always commonly at a greater risk of being exposed to environmental health hazards compared to their peers who are living in less racial and ethnically diverse areas. And so kind of just zooming out in general, such examples include Denver, Globeville specifically, right, which is a neighborhood that is split right by the I-70 corridor or the major highway here in the Denver metro area, and also Commerce City. And so we know this area is being heavily industrialized and near the major Suncor refinery. As a matter of land use policies, polluting industries are commonly built in low-income neighborhoods that have historically been the home to people of color, and this in Denver and Colorado is not an exception. These patterns again point to the systematically rooted policies that have continued to propagate these unfavorable outcomes for our communities of color here living in Denver and Colorado overall. And in these areas, we also tend to see higher rates of chronic disease and mortality and lower life expectancy, right? And so this continues again to call attention to the root causes, right, that are causing these patterns that we even see here on this map, caused by systemic and environmental racism. So for the sake of time, there is a language module, if I scroll up here, where we dive into language and compare COVID-19 diagnoses with a higher percent of people who do not speak English at home. But for the sake of time, we will pass on that. We do want to just encourage you to look at the map, as we do include a nod to important research from authors at CU in Denver Health, who found correlations between culturally accurate COVID-19 messaging and the importance of it during times of emergency, right? Which I think ties very nicely to our previous presenter who talked about the importance of culturally concordant representative communication, right, within public health in times of emergency. So definitely encourage you to take a look at our maps and please follow up with any questions or comments that you may have. I'm gonna go ahead and stop sharing this screen and share my next screen. All right, so now to dive into kind of some implications. The first one is that where you live in Colorado matters. And so our project, when it was released, was the first in Colorado to visualize the relationship between social barriers of health and COVID-19 diagnoses at the neighborhood level. Also from this, we were able to demonstrate that factors that were protective against COVID-19 or found to be protective against COVID-19 are not equitably distributed for all residents living in the neighborhoods of the Front Range. And lastly, that story mapping is a very powerful tool that is becoming more available for analysts like us. And CHI, alongside other groups that we've been working with and have heard of, are really diving more deeply into how these skills can be built up among not only our communities, but among the analyst community in Colorado and in Denver, and really be leveraged for good. So I'll go on to some lessons learned. The first one is to consider your audience. So indices may not be the most meaningful or practical for some members of your audience, right? So specifically, if you're wanting to reach audiences who are less technical or less data inclined, it's good to keep in mind, right, really being meaningful about how we're explaining an index or a percent of the average. That's definitely something to keep in mind. Another one is to always interpret your findings meaningfully. And so the patterns observed in this analysis are not, again, solely due to individual choice, but to the systemic and institutional level barriers that make it harder for marginalized groups to be able to pursue an education, for example. And lastly, preserve safety and confidentiality through data. So when going down to the small geographies like the census tract level, census tracts with 10 or fewer cases are not included in this analysis because of the small numbers of groups represented by those tracts. And so analysts at CHORDS naturally suppress sample sizes due to patient privacy and to exclude tracts with low CHORDS provider access and coverage. So we zipped through that pretty quickly, but thank you so much for attending our presentation and for listening. And so we're definitely open to any questions. I know that I didn't go into detail. So in our application, we do go into neighborhood specific comparisons and connections. And so we're super happy to dive into those and answer any questions. But yeah, thank you. Who has our first question?
Thank you both. Yeah, I didn't have to do my 2-minute warning. So we have lots of opportunity for questions for our two presenters. Feel free to unmute yourselves or put your question or comment into the chat. And I had a question, but as soon as I was like, I have to do my wrap up, my brain went blank. So
no worries.
Yeah, I've also dropped in the chat both a link to the mapping application that Guadalupe shared, as well as both of our email addresses if people are interested in the approach or the specific application we presented on today, or any of the other work that we've been working on recently at CHI.
Wonderful, thank you so much. So I am a doer-minded person, a data user-minded person, and so I'm wondering if at your organization, or if you know other organizations that have taken this visualization and used it in their communities.
Yeah, I mean, Lindsay, I feel like you and I have both worked on projects. One that I can think of in particular, and Lindsay, feel free to add. One I can think of in particular that I worked on recently is with a public health partnership where essentially, to inform their future COVID-19 equity strategies and who to target and focus on, you can essentially overlay, right? So you can overlay characteristics such as the ones that we showed, right? So neighborhoods within their community who have a higher percentage of non-English speakers or higher percentage people of color, overlay that on top of where the closest providers are. You could map, put dots in neighborhoods to represent a hospital or a clinic or a safety net area, right? And so it can be very informative because it's very spatial, right? And people who are from their communities, they know, and sometimes can perhaps better orient themselves, right, to see, oh, that's where I live, or that's where my friend lives, or that's where my organization is, or any of that. So that's one example. Lindsay, I don't know if you want to jump in.
Yeah, I'll just expand, on what you spoke about there. Is I feel like there is such a meaningful way that that people, I don't know, other mapping projects that I've worked on as well, is that I think people can really identify with these specific areas. So I'm from I'm from Colorado as well. So it's just like knowing these specific areas, especially in the Denver area where a lot of them are neighborhood level. I think people really identify with, this is where I live, and the implications that come with these data, I think really speak to that as well, and really help, I think, push forward policies when you can see these things visually. And it really, I don't know, it just feels like a big impact to be able to see these things right next to each other and be like, this matters. And like, this is a big implication for people that live in these specific areas of Colorado. And I don't know, I think that's what I really, I find really meaningful about whenever we do these kind of GIS related projects, is that people really are left with, I think, a different feeling when they can see it this way versus, you know, we write it in a report and they see some numbers.
Yeah, absolutely.
I'm thinking back to the last kind of comment from our previous speaker on like the seed, and I feel like this is a different type of seed, right, that may plant some information, make people more familiar with maybe some of the root causes, that we can take a step back and look farther upstream to be hopefully proactive in responding, or proactive instead of reactive. Any thoughts on that? Because I think sometimes we can maybe get stuck with like, well, this has already happened, so how can you take information about something that's happened and apply that to the future?
Yeah, I think one example that I was just thinking about, another one of our colleagues does a lot with the Metro Denver Partnership for Health that really brings together the 7 metro counties together. And I think what we kind of saw in that specific project around vaccine outreach and communication is, I feel like we can use a lot of this information when it comes to community outreach and community engagement, when we kind of move kind of combining both, like, here's information that we have, but how do we actually convey and make this meaningful for different collaborative groups in Colorado. And I think that's one aspect that I have seen, where instead of just like, you know, oops, it's been, you know, a year since these data came out, you know, like COVID's a big deal, but how does this impact kind of like as we move forward in dealing with the COVID pandemic, how we continue to collaborate and also continue to communicate these things, especially with, you know, vaccine hesitancy and other things like that that have come out as well. I think this has been a really interesting perspective to try to combine those two things to be more proactive in that way, is where we have this information. Okay, well, what do we do with it and how do we communicate it and use it to shape our kind of communication outreach efforts as we move forward?
Yeah, I'd love to add also kind of to piggyback off of what Lindsay is saying, is that, you know, the need to really power build within communities, right? But not only in times of emergency or not only when we're in crisis, but the sustainable and continued prioritization of community power building, right? Public health really partnering with local community-based organizations of all racial and ethnic backgrounds, right, or language, prioritization and all of that, right? I think one thing that happened, if, you know, for example, we're focusing on language, one thing that happened is that a lot of healthcare providers and people in public health, right, were sort of at a loss, right, to really, how do we message even vaccines, right? How do we message vaccines? How do we message testing centers, right? Who are the people who are already trusted that could have helped us with this, you know, earlier on, right? And not having to have built out those systems while the crisis was already happening. And so I think the message that I would say is continued and sustainable community power building and support, right, for communities to lead. They are the ones who know their community. They're the ones that know the need. And we as public health, I feel, are here, should be here to support, right, and help in any way that we can and provide any resources or information that we can. Yeah, and I think there was a question in the chat, can others access the CHORDS data set?
Yes. Yeah, I just dropped in a link to the CHORDS landing page that CHI collaborates with CHORDS to host this. And there is a lot of information and reports that are publicly available, like easily to access on this page. You can also request data. If you scroll down, there is a request form that you can also access. So it's a little bit different, I think, with the data that we received. It took a little bit longer to get that kind of data, but there's a lot more like summary statistics that you can request that I think happens a lot faster. You can get them by race, ethnicity, age, like lots of different demographic characteristics with all sorts of different diagnoses or screening type data. So there's lots of data available, and I would, yeah, you can peruse the website and see what's available, but yeah, we can connect you or kind of figure out if there's specific data needs, how to help you kind of get access to those as well.
Thanks for seeing that question and responding to it. Let's see. I had this question as well about the geographic scope of the data.
Yes, so the CHORDS network, I believe, is 14 different health system partners, and this includes, let me see, this includes Children's Hospital, Clinica Family Health, Kaiser Permanente, the Mental Health Center for Denver, lots of different partners, but it's not just limited to the metro area. It spans, I think, most, I'm trying to remember what counties, but it's mainly the most, the metro area, but there's lots of partners outside of just Denver County. But yeah, it's not representative of lots of rural areas in Colorado. I know that they're really working to increase the scope of this network and really trying to expand it. So they're always working forward to try to integrate as many different partners as they can, but most of them cover, most through the metro area, from Larimer County, I think, down to Pueblo.
Before I jump to that next question, I had a related one is, are you aware of any similar data sets that aren't CHORDS that could potentially be used to do similar mapping outside of the counties covered by CHORDS?
Yeah, I think one data set that is really helpful comes from CIVIC, which is the Center for Innovation and Healthcare something. I always forget what that one stands for, but that one is a database that does claims data. So that'll be more about coverage for those who have insurance. So it won't cover everybody, but it'll have lots of rich information there as well, that I think will be the entire state, much bigger scope as people are accessing kind of those access points in the healthcare system. That's one data set that I could think of that is available as well, that gets into kind of those diagnoses and screenings, similar to CHORDS, but has a bigger scope.
Thank you. And then the other question in the chat, did you find that race/ethnicity, language, and education were highly correlated? Were there any neighborhoods with discordant results between those three variables that surprised you? Find any ArcGIS limiting and accounting for any correlations?
Lindsay, I could take maybe the first one and you could speak a little bit more to the GIS limiting. So yeah, so race, ethnicity, language, and education, we chose to dive further into those variables because they were the ones out of a list that we were interested in that were the most highly correlated with our COVID-19 index variable. And so we had looked at other factors. Lindsay, feel free to jump in, but we looked at housing, housing instability,
income,
transportation measures like access to vehicles in the home. I'm not thinking about other ones, but yes, we had looked at a pretty good list of different indicators, and these three were the ones that popped out the most. Income, of course, was the one that I think was also highly correlated, but we figured that income kind of encompasses education, and so we decided to, and because income is kind of a more sort of like arching variable, we decided to go with education. And then in terms of any neighborhoods with discordant results between those three variables or neighborhoods, honestly, we did see the trends that we were expecting to see. I think I should have pointed out the inverted L, which a lot of us might be familiar with, right? So this inverted L going from Southwest Denver all the way to like Northeast Denver, right? And kind of like in the middle, Central Denver not being as highly impacted, right? And so this inverted L is seen with all kinds of different health outcomes, right? Higher rates of diabetes, lower rates of life expectancy, morbidity just in general. And so we weren't really surprised. And if you go into the application itself, we do like zooming in of specific neighborhoods as the one that I showed when we zoomed in for all of the different indicators, right? So language, education, et cetera. Lindsay, I don't know if you'd add anything to that.
No, I think that covered, I think, a lot of the findings piece, but yeah, I really like this question about, working within the bounds of kind of these different, I don't know if it's like Tableau or if it's whatever kind of visualization softwares that we use for kind of this I don't know, this idea that we kind of work within what we have. And I think ArcGIS Online, it was able to give us what we needed for this specific project, but even just the application itself, these are all pre-built by web developers, and people do have like coding experience to actually build these applications themselves. But like, even for us, I think we are still kind of limited in what is, available on those applications. And it's trying to find a way to basically use what is already pre-built to really try to showcase and tell this story the best way that we can. So I think like for this specific project, we really, we tried different applications that, we were like, no, this one doesn't really work for what we need. Like how can we kind of, even just the story map itself, when you go on there, like how can we, as you scroll through it, what is the best way to really showcase and tell this story as you go down? So I think it's less about the limitation of the application and more about like the communication side. I think that is really where we spent the most time really trying to be like, well, how do we talk about these data? Like, how do we make sure that we paint the picture in the way that is representative, that really, doesn't, put blame on specific communities, that doesn't like, there's such an important communication piece, I think, when we talk about data, that is almost more of the limiting factor, that you need to be able to communicate these things in a way that has a wide audience in mind, but also showcases the information and represents it accurately. I would say that is more of the limiting factor in being able to show and also talk about these data in a way that feels meaningful.
Thank you both. That's about our Q&A for your session specifically, but we do still have some time. This session wraps up at 11:30. So I also want to open it up to any questions that people might have thought of for Lindsay, our first presentation, and then any other questions for our second presenters as well. And or final remarks from our two presenting groups as well. I taught a class, so I tried to get comfortable with silence. I'm one of those people that takes a while to maybe get up my nerve or might come up with my question and then unmute myself or type it in the chat. But don't need to let this linger, knowing it's a Friday, almost afternoon. Either of our presenting groups have any last points that you wanted to share with this group before I say some final announcements?
I don't think so. Just to thank everybody for coming and for all the really good questions.
Yes, and everyone, please feel free to send any comments or thoughts or feedback. We love to hear it. So yeah, thank you all for having us.
Yeah, I would just echo the same. Thanks for having me, and I would love to connect with anyone, and thank you all for the questions.
All right, well, thank you all for attending this session. If you want to reference the slides or any materials, that's on Sketch. And since we're at the end of the conference or coming up on the end of the conference, just want to remind you again about the evaluation form that'll be coming your way. We really, really want our attendees to provide us feedback so we can make the conference even better in the future. This is our last concurrent session, the last live session, but we're not done with the content yet. There's one more walk and talk available for you to listen to while you step away from your desk. So feel free to do that. The title of this presentation is Words Matter, How What You Say and Don't Say Influences Wellness. And after that, our conference for 2022, I know what year it is, will be officially over. If you enjoyed this conference, we encourage you to check out Public Health in the Rockies. I think they extended their abstract submission deadline, so check that out if any of you as presenters or attendees want to submit to that. And thank you so much for supporting CPHA and for joining us for our 2022 conference. Really hope you had a great couple of days and look forward to connecting with you in the future.